Welcome to the TMI Doctor, talking all things TMI and health and wellness. Here's a highlight from today's episode.
The literature to date has showed that the hormone therapy will not cause you to have cancer. So that's a common
Oh,
misconception.
really? Okay, so
Yeah.
that's a huge
No,
one.
no, I mean, if you have a family history, then we automatically know that you're at increased risk. And that's something that we take into consideration when you're treating you. Because if you do have, a breast cancer, and it's responsive to estrogens, if you're taking an estrogen, you could feed the cancer, but there's no causal effect there.
That's
Uh,
great to know because I think a lot of people are terrified of it because they're like, well, this is going to cause me to get cancer, so I'm just not going to do it. And that's a very, very frequent thing I hear from my patients. They're like, oh, I don't know about those hormones. So that's amazing. If no one remembers anything else from this episode, like it does not cause cancer. So, it can increase, it sounds like it, if you have a possibility of it, you should be mindful, and keep your preventative care up. But it sounds like as long as you're doing that, you should be doing okay. So, hello, I am Dr. TMI, aka Dr. Tanya Yannick, with the TMI Doctor channel, and I am here with Elisabeth MacDonald. She's a physician assistant. We used to work together a few years ago on Cape Cod, and now life has brought us more to the mainland. Lots of life changes. So, I'm super excited to bring her on and talk about some of the stuff that she's learned in urology, especially about hormones. Elizabeth, tell me more about what got you into urology and physician assistants.
Good morning, Tanya. Good to see you again.
Yes.
Um, I've been working in urology for my entire career. Prior to being a physician assistant, I was a medical assistant working in urology as well. I enjoyed it because it's a surgical subspecialty. So there's some in-office work. There's also the opportunity to do some work in the OR as well. When I first started in urology, it was more, general urology, a lot of BPH, which is prostate enlargement, a lot of overactive bladder. A couple of years ago, I started working with a urogynecologist and started learning more about urogynecology and some of the pelvic floor dysfunction that can occur with women. Working in Cape Cod, you're probably aware that sometimes there's very limited resources to providers.
Oh yeah,
Um,
definitely.
so when I joined the urology practice down in the Cape, I was one of the only female providers offering urology down there. So I got a very large amount of female patients. So I was very thankful to learn about urogynecology and start learning more about prolapse and pelvic floor dysfunction. And more importantly, atrophic vaginitis, which I think is, a urological, gynecological condition that's oftentimes, overlooked and under acknowledged even by patients themselves. They know that they're having these symptoms and they just kind of associate it with, old age,
Yeah.
and something that just kind of happens with time and there's not too much that you can do about it. Versus, this is something that I need to address with my doctor because there may be an easy solution or an easy fix. So
Definitely.
atrophic vaginitis was kind of my introduction to localized vaginal hormone therapy.
Awesome. Yeah. So that's what I was excited to bring you on about because from my end, clinically, I see a lot of pelvic floor clients come in and they're usually mid to late 30s, anywhere up to 40. It's usually mid to late 30s to 40s. And what I found interesting is like I can tell the difference when I do an assessment. Like, okay, there's discomfort from musculoskeletal issues like a tight, like strained muscle or a tight muscle versus like I'm barely touching them and their skin is raw, their skin it feels like, they just keep on saying it feels raw or like razor blades or like it's just agitated. And then it's interesting because it's usually a constellation of symptoms. They'll say, oh yeah, suddenly I started leaking more, suddenly I'm getting constipated, suddenly I'm feeling pressure, suddenly like, and then they blame it on their children, but their children are like 8, 10, 15 years old. And I'm like, I mean, that might have made you prone to it, but I've treated people with these symptoms that never had children. So I'm like, that's not the reason. So that's where I started learning more about because most people know about menopause and they're like, well, I still have my period, so it's not menopause. And then I learned about perimenopause that can be 10 years beforehand. So I'm like, okay, well, at least me and my friends feel validated because I'm in my early 40s. And, starting in the late 30s, some of us were starting to get like, a little bit of joint pain we didn't have before, but we blamed it on the sports we did. And we started getting a little bit of this and that. And, you're just blaming it on like, okay, I guess I'm just getting old.
Every
But
day.
then I realized like the hormones are going up and down. And then even in the clinics I've worked, I've referred out like, oh, well, maybe your hormones are off. Let's refer you out. But I didn't realize like you can have basically menopausal like symptoms, but have normal lab values. So that's
Mm.
what I want to talk about because I'm like, that blows me away. And I've heard sometimes you just go based on the symptoms versus the labs. And like, it's just, and there's conflicting evidence. And there's also the old research that says hormones are bad and you should just sign up for your mastectomy if you have, like any breast cancer history. So, and now they're debunking that to a point. I know there's still a risk, but like it's fascinating because I'm like, okay, there is help. And I've heard people went on the hormone treatments and they're like, oh my God, it's like they got their life back.
Life
So,
change. I
I'm
hear it
like,
very
where,
often.
yeah. So as it like, so when I see these patients, if I referred them to you, like what would be the first thing you do? Is there lab testing? Are you going off their symptoms? Like, what are you looking at when you're considering HRT hormone?
Both.
Yeah. Okay.
Yeah. HRT stands for hormone replacement therapy. BHRT is a very common term that stands for bioidentical hormone therapy.
Got it.
But to answer your initial question is we assess both. Um, and you made a lot of really valid points. There's a lot to be known about hormone therapy. A lot of the older literature, which we can talk about next, kind of made it this taboo area of medicine that people didn't want to practice, people didn't want to talk about, patients were scared of. And that has significantly changed with newer research. But going back to your initial question, hormone therapy is tricky because it's complicated, and you have to know your patient, you have to know their history. So when I see patients, I do a full medical history, a full family history. We talk about symptoms. There's typically about a 20 question survey that I ask patients to fill out before the visit, so that way we can review it at the visit. Usually based on that survey, I can kind of get an idea of what their labs are going to look like just based on their symptoms. Um, every hormone patient is different. Hormone therapy is very individualized. There's no standard starting dose for everyone because really it does depend on their symptoms, their lab values, and their history and their family history. A lot of the times, just taking a history, you can determine whether a patient is lacking estrogen or even is living in an estrogen dominant state. Just by identifying some current health conditions that are going on. We do check lab values. Typically, I like to meet with patients first and have a pretty extensive appointment. It's usually about 30 minutes to an hour, just kind of talking about the history and the symptoms. And then we'll draw some lab values after that, review the labs at a second appointment, and then kind of talk about treatment options, based on the whole history and what they're experiencing and their lab values. With hormone therapy, I think the overall goal is to, alleviate symptoms,
Yeah.
improve quality of life,
Yeah.
keep the body healthy. And my theory on it is to do so with, the least amount of medication possible.
Awesome.
So it's kind of just bringing people back up to their hormone levels if they are at insufficient values, and to not go over too far to the other side, so that they're developing any side effects from having too much hormone levels. So it's kind of a balance where we're optimizing their hormone health without going too far and creating any side effects.
That's great. That's awesome. Yeah, it's really the quality of life because, you suddenly start leaking, you're not having intimacy with your partner because it is uncomfortable. Like those are all sorts of things that end up being a problem. And, it really, I've heard the awful things from the doctors saying, just drink a glass of wine or, oh, you're not menopausal. So I don't like, they're basically medically gaslit and told like, no, everything's fine. I don't know why you would be having these symptoms. And, to understand, there was a graph I saw and it shows like, when you're in like your childbearing years, it's like a nice even cycle. And then in perimenopause, it looks like a roller coaster. It's like down for a little bit, then it's up, and then it's down. And I'm like, no wonder you feel a little like the mental health kind of goes downhill a little bit. And of course, all these women are in the prime of their, a lot of them are in the prime of their professional lives, and also they're in the middle of like child rearing. So I'm
Sure.
like, the
Very
combo
true.
is just, so they're just maxed out and trying to get them help. So if we can get them any, I can do so much with physical therapy. Like sometimes there is secondary muscle spasms, sometimes there's just behavioral things. That's the most fun where I just have them adjust a few things and they're like, oh my gosh, apparently I shouldn't drink coffee, seltzer, and wine all day. So, which is usually the rotation, right? From start to
Yes.
finish. Not to say you can't have it, but maybe get some normal water in there somewhere so you're not irritating your bladder all day long. But then there's the stuff that we can't help where I'm just assessing their pelvic floor and I'm just like, oh, this symptom is definitely not like we can only get it so far, but there's a primary driver. What I'm dealing with is addressing the secondary, muscular reactions to the discomfort they're feeling from the drop and, whatever, if it's estrogen. And
Sure.
so explain that a little bit more because I know there's a drop in estrogen, but I know progesterone and even testosterone is like huge players, which women are like, we don't have testosterone. I'm like, no, 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 we do. And so they blame estrogen, but I feel like the other two are little like rogue guys causing problems too. So what's the difference
Yes.
here?
So, I mean, with hormone therapy, it's all about balance. And all three sex hormones are crucial with women. And you're absolutely correct. Average age of menopause is about 50 years old, give or take a couple of years. So women can start to experience symptoms of perimenopause in their late 30s. And you're absolutely right because they oftentimes go to, their GYN or their PCP, and they 100% get responses like, oh, well, you're too early for these types of symptoms. Or
Oh,
sometimes women who are older, they hear, oh, this is signs of perimenopause, but we're women, we just, suffer through it, it'll get over, and you'll be fine. Or, they'll prescribe medications, to treat the symptoms versus addressing the actual problem, which is, a hormone insufficiency. So they'll recommend, SSRIs for mood or, melatonin for sleep or even, prescription sleep medication. And they tell you, just suffer through the hot flashes, they'll
yeah.
stop. When really, just fixing the estrogen levels will address your hot flashes within a matter of days or a week.
My gosh, that's amazing.
Yeah, it really is. And you're absolutely correct. All three hormones are crucial. When we check hormone levels, and most of the time, primary cares and GYNs don't really want to test these levels because within your 30-day cycle, if you're still cycling, your hormone levels are doing different things. So you really have to look at your labs in reference to where you are in your 30-day cycle,
Oh my
to
gosh.
really determine whether your hormone levels are off or not. And sometimes we even have to check it twice in your cycle because women will tell me, I'm experiencing symptoms during this specific part of my cycle. And we might test their hormone levels and they're normal, during the follicular phase, which is the first half of your cycle. And then it's during their luteal phase that, their estrogen shoots way up and they end up in an estrogen dominant state. So you really have to listen to your patient and what they're experiencing, and kind of test based on that.
And what's
Um,
wild, I know, is I ask my patients about kind of their cycle and everything. The IUD has like taken over for a lot of people, which is great. We're all like, "Woo, no period," but we have no idea what's happening with our cycle then. So
that
that's
is correct. That's a very
another
good point.
problem when I've asked them, like, try to screen those questions. I'm like, "Do you have difficult periods? Have they become irregular?" They're like, "I don't know. I haven't had a period in 5 years since I put my, IUD in." I'm like, oh,
Correct.
well, we have no idea where we're at.
And at that point, usually we can look at symptoms and things like that. If it's an older woman, then we have to check FSH to basically determine whether they may be in menopause or not.
What's the FSH?
FSH is follicle stimulating hormone. It can be an indicator of menopause, but again, the true clinical definition is 12 months
Oh,
without a menstrual cycle.
okay.
Um, so as your estradiol levels go down, your FSH goes up. So you can get kind of an idea with a woman who is not menstruating, not having a cycle for whatever reason, IUD, or maybe we suspect premature ovarian failure. A woman who's had her uterus removed. In those cases, we have to check FSH because, of course, they're not, bleeding vaginally to give us an idea where they are in their cycle. Um, but to go back to your original question, when we're checking a hormone panel, we don't just check the sex hormones. We check a couple of other tests as well, and thyroid, because a lot of your hormones
Oh,
go
okay.
hand in hand with one another. Um, so typical symptoms of low estrogen. Do you want to take a couple of minutes and go over the
Yeah, sure.
hormones
Yeah.
one by one?
Yeah.
So typical symptoms of low estrogen, you can have the vaginal symptoms. So, having some urinary changes, frequency, urgency, some increased urinary leakage,
Hmm.
vaginal dryness, pain with intercourse. And these symptoms are not always specific to just one hormone. So you'll find as we start to talk about some of the other hormones, there might be some overlap. But cognitive changes are often associated with low estrogen as well. So brain fog,
Hmm.
forgetfulness, poor memory, poor concentration, mood changes. Hormones are really controlling every system in your body.
Hmm.
Um, so a lot of the times I'll see women and they're like, my husband is about to divorce me. My colleagues hate me.
Yep.
My kids hate me. Like, yeah, they're just, having a really hard time with these hormone changes. Estrogen helps to keep your cardiovascular system healthy. It actually helps to maintain the elasticity of your blood vessels. Your blood vessels are constantly dilating and constricting, so it actually helps to control your blood pressure and keep your cardiovascular system healthy. Um, Estrogen is responsible for collagen production.
Oh,
Um,
wow. Okay.
so
So
you
that's
start to have
why.
some,
Yeah.
yeah, some hair, some
Yeah.
skin, nail changes. But more importantly, people start to forget that our ligaments are made up of mostly collagen.
I am feeling
So
that, the joint pain, man. I'm like, or I'm an orthopedic, I have an orthopedic background, and noticing that I'm like, this is not making any sense. I know what like a strain or a tear is, and this
uh,
is feeling like that, but this is coming out of nowhere and moving around. And I'm
So
like, what?
testosterone is also largely responsible for some chronic joint muscle pain
Oh, okay.
and muscle building and muscle repair.
Yeah.
And we'll talk about testosterone next. But some of the other big symptoms of estrogen deficiency or insufficiency, hot flashes, night sweats, those are some really big ones as well. And there's probably a whole bunch more, but those are kind of the big ones that come to mind. Um, Moving to testosterone, because we were just kind of chatting about it. You're correct. Women oftentimes don't think that's a big player because they just think estrogen and progesterone, but it's huge. It's equally important for women as it is for men, and it typically starts to slow down in the 30s.
Yeah.
Um, and that holds through for most of the hormones. When you think about it, growth hormone peaks when you're in young adolescence, and then after that, it starts to slow down.
Mhm.
And it's just a natural part of aging. But part of the, purpose of hormone therapy is to just, replace these hormones with bioidentical hormones that are identical to the hormones that are naturally found in your body, to keep your body healthy and to prevent, changes in the cardiovascular system, the skeletal system, your hair, your skin, your nails. Obviously, the aesthetic stuff helps as well.
Yeah.
Uh, but testosterone is so often overlooked. It controls your libido, your sexual sensation, and a lot of the times women are kind of shy to talk about that. But it's such an important part of life, even as you get older. Um, so
And I
that's
think
one of
it's,
the
oh, sorry.
yeah.
I think it's important to point that out too, because I spend a lot of time talking to these women that are coming in for their pelvic floor dysfunction, and they've just written it off. Like, usually they're coming in for one thing, and I do a thorough history. They're like, oh, but I've been married a long time. Oh, I got the kids. The libido's not there. That's just what happens when you get old and you've been married a while, and like, I'm like, Yes and no. Like everyone uses it's getting old, which is kind of true, but also it's an indicator. It's symptoms of something else. So that's what I want to like really put a spotlight on. It's like actually there is help and things that can change with it.
Yeah,
Especially now that there's new research coming out with the hormone replacement therapy, and it's, I feel like it just got like, that old research that actually ended up being skewed and incorrect. Actually, I feel bad for that generation of women that were just like, just put up with it. And they were probably suffering so much. And there's so much more we can do for them. And not to be scared and not to just brush it all off as like, this is just what happens. Like, it is what happens, but can we treat it? Yes, yes, we can.
absolutely.
We don't have to suffer and we can get back to active, vibrant lives.
Yeah, and it can be easily treated and safely treated.
Yeah.
So, testosterone overlaps with a lot of, the estrogen symptoms as well. So it can help to improve some vaginal dryness, some stress urinary incontinence, because testosterone helps to build muscle.
Yeah.
It helps with muscle repair. It helps to build muscle. We've all seen, these little people that are in nursing homes and they're just skin and bones. They have no muscle
Yeah.
left. It helps to build muscle. And think of, the role of your pelvic floor. If you can improve those muscles with a little bit of, small dose testosterone, you could help to improve, urinary incontinence.
Yeah.
Um, Another big correlation with testosterone is mood. People who
Mm,
tend to have low testosterone tend to feel kind of sluggish and depressed. So it does help prevent and improve depression.
mhm.
Um, and it gives energy.
Yeah.
Um, yeah, so there's a lot of important factors with testosterone, on top of the increased libido and sexual sensation and things like that.
Yeah.
Uh,
That's
and
great.
then the other important hormone is progesterone.
Yeah.
Um, Progesterone plays a lot of important roles in pregnancy, but it's primarily known as like a sleep hormone. Um, women,
Oh.
yeah, women
Is
who are
that
going.
why we have trouble sleeping as we get older?
Yes, yes. And a lot of the times it's not so much difficulty with falling asleep, it's difficulty with staying asleep. So a lot of women will be like, I fall asleep, no problem, and I might sleep for an hour or two. And then after that, I'm waking up for the rest of the night and I just can't get, a full night's sleep. Most of the time that's a sure sign of a progesterone deficiency.
That's great. I
So
know friends dealing with that, so I can be like, we need to get you on some progesterone.
it can also help with mood.
Okay, great. Yeah.
Um, I mean, progesterone's a really safe hormone. It can be taken orally. Um, and it's usually taken orally when somebody is experiencing, some sleep issues. That's the way that it kind of improves things the quickest. So you would take it at night.
Yeah.
So
Great. That was an awesome overview because I know like the broad strokes, but that's why I needed someone like you to come on that does, treat all this to
yeah.
explain all that. So
And then
what would be
I
some, oh, sorry.
sorry, I'd also mentioned, we check thyroid panel as
Oh
well.
yeah.
Because just like all other hormones, thyroid tends to decline with time as well.
Got it.
But there's an interesting correlation between estrogen and thyroid that
Mm.
a lot of people aren't aware of. When your estrogen levels are low, it tends to pull down your thyroid function.
So
So when
everyone
I
ends up
see
with a little
somebody,
hypothyroid. Yeah.
yeah, and I mean, when you think about some symptoms of menopause collectively, weight gain, low energy, a lot of those symptoms kind of overlap with thyroid symptoms as well.
Yeah.
So when I do an initial assessment, I'll definitely look at thyroid. If it's just slightly low, I'll follow it and with the goal of improving estrogen levels. And most of the time, when we recheck labs, we see that as estrogen starts to come up, thyroid function comes up as well.
That's great. That's
Yeah.
awesome.
So there's a
So
very interesting correlation.
yeah. So when you're assessing people, is there any point that you'd say like hormone therapy is not for you? Like what are the red flags that they really shouldn't do any hormone therapy?
So I've collaborated a lot with, breast surgeons and oncologists as well as, urogynecologists. If you're actively being treated or investigated for breast cancer, then you should probably, definitely put your hormone therapy on hold.
Okay.
Um, you want to find out if it's, hormone related. And if so, if it's, estrogen dominant, progesterone, So anytime we do require our patients to have their regular preventative screenings,
Yeah.
so mammograms, pap smears, colonoscopies. And if at any point of time those are abnormal, we want to make sure that they get a further workup. So if somebody comes back and they say I have an abnormal mammogram, we simply just put the hormone therapy on hold until it's further investigated.
Okay.
If it turns out to be a benign lesion, then they can restart.
Great.
Obviously, if they do have a breast cancer and it's, estrogen dominant, then we would not want to be giving them any type of estrogen therapy or progesterone or even testosterone, because testosterone undergoes a process called aromatization where it does break down into an estrogen.
Oh, gotcha.
And the last thing that we would want to do is to be feeding somebody that had, an estrogen breast cancer,
Yeah,
estrogen.
definitely not. Great.
Um, so we just kind of put everything on hold. It depends on a lot of factors and it's a very, individualized case. But as I had mentioned before, I've collaborated with a lot of, breast surgeons and oncologists because, people that have, their ovaries removed, especially at a young age, prophylactically because they have a family history, you still do need some hormones to keep the rest of your body healthy.
Yeah, I always find that interesting that especially when it is any sort of cancer or family history of cancer in the reproductive area or anything that's going to affect the hormones, it's this catch-22. I feel like that, yeah, we want to prevent the cancer, but then also it's now we're getting rid of hormones that are going to cause a cascade of other problems. So it's delicate. It sounds like it's a walking a tightrope a little bit. Like we don't want to do too much because we don't want to, feed the cancer or potential for that, but also we want to keep you lively and active and
Yeah.
feeling good. So,
And
so thank you.
the
Yeah.
literature to date, has showed that the hormone therapy will not cause you to have cancer. So that's a common
Oh,
misconception.
really? Okay, so
Yeah.
that's a huge
No,
one.
no, I mean, if you have a family history, then we automatically know that you're at increased risk. And that's something that we take into consideration when you're treating you. Because if you do have, a breast cancer, and it's responsive to estrogens. If you're taking an estrogen, you could feed the cancer, but there's no causal effect there.
That's
Uh,
great to know because I think a lot of people are terrified of it because they're like, well, this is going to cause me to get cancer, so I'm just not going to do it. And that's a very, very frequent thing I hear from my patients. They're like, oh, I don't know about those hormones. So that's amazing. If no one remembers anything else from this episode, like it does not cause cancer. So, it can increase,
yeah.
it sounds like it, if you have a possibility of it, you should be mindful and keep your preventative care up. But it sounds like as long as you're doing that, you should be doing okay.
Mhm.
Awesome. So where can people find you if they are loving this episode and they're in Massachusetts and want to come see you? Is there social media? Is there an office you're at? Like where would they track you down?
Great question. So I'm working at MetroWest Urology, treating urology and urogynecology patients. Um, and I'm happy to offer bioidentical hormone therapy through the urology side of things. And then we also have MetroWest Medical Wellness, where I offer bioidentical hormone therapy as well as weight loss therapy.
Great.
So you could visit our website. The website's just www.metrowesturology.com. Or you can just give us a call
Yeah.
at any point of time. We can get people in pretty quickly, and do a hormone assessment. The other thing that I think is really important to note, with hormone safety is, the difference between bioidentical hormones and synthetic hormones.
Oh yeah. Tell us more about that. Yeah.
Should we have a couple of minutes to kind of chat
Yeah.
about that? Yeah.
Yeah. Just a couple. Yeah.
Perfect. So standard, hormone therapy sometimes included use of synthetic hormones, which are lab created. Bioidentical hormones are actually derived from either yam or soy, and they are identical in structure to the hormones that are naturally found in your body.
Wild. That's good to
So
know.
they behave exactly the same,
Yes.
meaning there's no increased risk of side effects or adverse reactions or events, because they're the same as what's naturally found in your body.
Mhm.
Um, the compounding pharmacy that I use, they strictly use yam versus soy, just because a lot of people are increasingly having soy allergies. So we just use yam derived hormones. But it's really interesting because a very common question that people ask is, is there any way that this hormone therapy could interact with any other medications that I'm taking? Absolutely not,
Okay.
because
Yeah.
the hormones are already in your body. They're identical in structure, so you know that it's not gonna, prescribed at the appropriate dose. Um, Really, you should just improve your quality of life and alleviate your symptoms, and not experience anything more as far as side effects go.
That's awesome. It's great to know.
Synthetic hormones having different structures, uh, that is where the concern actually comes in. There's a lot of adverse reactions or actually risk of cancer. That's where the risk of cancer can come in with synthetic progesterone specifically, and sometimes synthetic oral estrogens as well.
Okay, gotcha.
The form of hormone therapy is really important for the safety and the body. So we don't ever prescribe oral estrogens just because it
Yeah.
increases your estrogen levels very high. And your liver has to basically break it down. It undergoes a process called, um, sorry, drawing a blank.
Yeah, it's all right.
First pass metabolization,
Yeah.
where you end up having high estrogen metabolites, and it throws up your sex hormone binding globulin, which is a protein that responds to high hormone levels in your body.
Okay.
Uh, so all of the research that has been done on hormone therapy really shows that transdermal hormones are completely safe and effective. And it's kind of the gold standard for hormone therapy.
It's great. Yeah. I've heard of, I might be incorrect, but I swear I heard that even people actively dealing with breast cancer treatments are sometimes still on like the cream, like the very localized cream, if they're having some severe symptoms. Like that they like some oncologists are like, it's small enough and it's local and it's not going systemically that they weren't concerned about it if especially
Correct.
their quality of life, like there's
It's
other
really tricky. You are correct. It definitely is on a case by case basis.
yeah.
So if anybody is ever on an estrogen suppressant, you have to be careful about giving them a transdermal cream, which absorbs right into the bloodstream and your body's readily available to use that. It doesn't undergo that first pass metabolization. And in most cases, it can be used. But of course, um, I always check with the patient's oncologist first and just get, they're okay because really, we work together, we collaborate. 99% of the time, localized vaginal estrogen is encouraged with these patients because they experience a lot of vaginal
Yeah.
atrophy. And the research on vaginal estrogen is that it's localized, it's not systemic. So vaginal estrogen's not ever gonna improve, systemic symptoms such as, hot flashes, night sweats, mood changes, things like that. But it's still really important because restoring your vaginal tissue is important for improving pain, urinary symptoms, urinary tract infections, leakage, things like that.
Yeah. Yeah, that's what
All
I
the
see
things
all
that
the
you're
time.
seeing on a
Yeah, that's what I
regular
see
basis.
all the time. I'm like, get your hormones checked. And then I was like, oh, everyone's coming back with normal labs and no treatment. And I'm like, okay, I guess we just have to wait till you hit menopause, which that's not any fun. That could be 10 years. So,
But
well,
hormone therapy, given, the appropriate route of administration and, your medical history is 100% safe, effective, even for women in perimenopause.
great.
Yeah.
Well, thank you
Just
so much. Like, this has been incredible. Is there
yeah.
anything else, any other last tips that you wish everyone in the world could know, or at least all the people with vulvas could know in the world?
There's hope out there. There's
Yeah.
there's there's a fix, there's
Yeah.
treatment. And we always like people to know that we monitor very closely. It's very individualized care. Um, After starting on your hormone therapy, we check in about 4 weeks just to see how you're doing. At that 4-week visit, the feedback is always amazing to hear because people are like, this has changed my life. This is amazing. Uh, and then we typically recheck all of your labs in about 3 months. A lot of the times these therapies require, some minor adjustments.
Mhm.
And it's common. And that's why we monitor so closely. We'll continue to monitor your labs every 3 months or so until we get the right dose for the patient. And then after that, we monitor labs about every 6 months, so twice a year, just to make sure that everything is, in a good range.
Yeah, that sounds great. Well, thank you so much for your time. Thanks for coming on, and hopefully, I've learned a lot, and I'm sure my clients and my people watching will definitely learn a few new things. So thank you
Thanks
so
for
much.
having me, and don't ever hesitate to reach out with any questions.
Oh yeah, I bet you there's gonna be questions. We're gonna have to do part 2, 3, and 4. So I'll be in touch.
Love talking about it, so
All right, awesome.
I look
Well,
forward to it.
thank you
Thank
so
you.
much. All
Take
right,
care.
have a good
Bye.
one.